Hello everyone and welcome. My name is Sven de Keyser. I'm a neuroradiologist working at Ghent University Hospital in Belgium, and this video will provide a short introduction to the physical basis and interpretation of some advanced MRI techniques. These techniques are called advanced. I'm going to introduce them to you. So this is going to be a basic introduction for people who are new to the field or who just want a refresher on techniques that are not often used in daily clinical practice unless you work in a university center where they are more standard or you do research or something like that. I'm going to talk about functional MRI in this presentation, MR spectroscopy, diffusion tensor imaging, and MRI perfusion. I'm going to start with perfusion MRI, and what is perfusion MRI is basically not one specific sequence, but a variety of MRI techniques that allows us to give some insights into the perfusion of tissues by blood. We can perform perfusion MRI images in several ways. We can do it without gadolinium, so-called arterial spin labeling, but we can also perform perfusion MRI with gadolinium. And then there are two techniques, the dynamic susceptibility contrast enhanced technique and the dynamic contrast enhanced technique. In our center, we only do dynamic susceptibility contrast MRI perfusion. So the images I'm going to show you are dynamic susceptibility contrast images. And what's the basis for dynamic susceptibility contrast? Well, basically the patient receives a bolus of intravenous gadolinium, and this is paramagnetic and will cause a signal drop on T2 star images, and basically we visualize that T2 signal drop. We use it mainly for evaluation of brain tumors, and then there's one parameter that's important, that is cerebral blood volume, the volume of blood in a certain amount of brain tissue. So what I'm going to show you are mainly tumor patients, and I'm going to show you the cerebral blood volume map. Why do we use MRI perfusion? What are the indications? Ischemic conditions, and then especially patients who have a chronic stenosis or Moya-Moya syndrome, for instance, and whom we want to evaluate the so-called cerebrovascular reserve. We want to have an idea of the degree of perfusion of the brain parenchyma and evaluate if this brain parenchyma is hemodynamically at risk. This can guide treatment decisions. It's also used a lot in brain tumor patients because it can give us an estimate on whether or not we are dealing with a high-grade or a low-grade tumor, and it is used in the follow-up of tumor patients, and especially in patients who have received radiation therapy, it can be extremely useful. Because a common complication of radiation therapy is so-called pseudoprogression. So we get new contrast-enhancing lesions in the location where the radiation was given, and that can look a lot like tumor, but isn't. This generally occurs in the first weeks to months after the radiation therapy. And we can also have radiation necrosis, which is more of a delayed complication, in which the tissue in the radiation field becomes necrotic, but that can also look on conventional MRI images like a brain tumor. And we will see that perfusion MRI becomes really handy to differentiate these entities. This is an example from daily clinical practice. This is a glioblastoma, and this was a 30-year-old female patient, I believe, or somewhere in her 30s, and we see a tumor that even with just our conventional MRI images would have made us suggest glioblastoma. It is a high-grade, it is an aggressive-looking lesion with a large kystic component and a solid irregular enhancing component located in the parieto-occipital lobe. And on MRI perfusion, so we see contrast enhancement, but in the end, contrast enhancement only signifies that blood vessels are leaky and the blood-brain barrier is deficient. It is not necessarily a sign of dealing with a high-grade lesion. We also see, however, hyperperfusion. We see that the colors are, well, it's pretty colorful over there on these MRI perfusion reconstructions. And hyperperfusion, so this is the cerebral blood volume map. So basically we are looking at an increased local blood volume over there. How come? Due to neoangiogenesis, high-grade tumors tend to develop their own blood supply, and the microvascular density of high-grade tumors like glioblastoma is higher than that of low-grade tumors or of normal brain parenchyma. So if you do perfusion images, we will see an increase in the cerebral blood volume in these tumors, as we can see here. Now, the diagnostic value in this particular case was not very high, because anyone would probably suggest glioblastoma as the number one differential diagnosis when confronted with a tumor like that, but there are situations where MRI perfusion can provide us with some additional information. Let's look at this patient. This was also a patient with a glial tumor. This is the glial tumor on the FLAIR images. So we see a diffusely infiltrating lesion located in the region of the left basal ganglia, also involving left insular cortex and the left temporal lobe. And on the T1 weighted images with gadolinium, we see that there is a focus with nodular contrast enhancement. Now, if we just were to have these two images and our surgeon would ask, where should I perform my biopsy, we would probably say, do it in the region that is contrast enhancing. But as said, contrast enhancement is not necessarily a sign of a high-grade focus. It's only a sign of a region where the blood-brain barrier is deficient. So we try to get some extra information and we do an MRI perfusion. And then we see that this nodular lesion also has an increased perfusion compared to the surrounding brain parenchyma. Now, this is a sign of neoangiogenesis, and this makes it very likely that this particular part of the brain tumor is high grade, and this is the best target for a brain biopsy. So, in glial tumors, performing an MRI perfusion can guide the biopsy location of the neurosurgeon. It can also help us estimate on whether or not we are dealing with a high-grade or low-grade tumor. This was also a glial tumor. This was a diffuse astrocytoma, and it looks very big, it looks a bit ugly. Simply based on the size of the thing, our gut feeling says, oh my god, let's hope this is not malignant. Now, WHO grade 2 tumors are not innocent either, but if you can choose between WHO4 or WHO2, I'd still pick the 2, of course. Well, if we do an MRI perfusion, we see no hyperperfusion in this mass whatsoever. Let this not confuse you, these were just some blood vessels located in this sulcus, which is a bit hidden by the tumor over here. So these are not areas of hyperperfusion. There was no hyperperfusion, so we suggested that this is most likely a lower grade astrocytoma, and it was effectively a diffuse astrocytoma WHO grade 2 tumor. In this next case, we see several areas of tumor infiltration. This is also an astrocytoma. This is a glial tumor, and we see tumor infiltration, FLAIR hyperintense, in the hippocampus on both sides and the right side of the midbrain. Now, in this case, we don't see any contrast enhancement whatsoever. So where best to perform a biopsy if you were to do one? Well, we see this area of hyperperfusion located in the left hippocampus, which is very suggestive of high grade, and this was a WHO grade 3 astrocytoma, so it was high grade. I do not remember if the biopsy was effectively done over there or not, but this was definitely the region we would have suggested, despite the fact that it's the hippocampus, which is of course very important for our memory function. So it's definitely a decision that has to be weighted, or it's not an easy decision to make, of course. Let's move on to MRI spectroscopy. As said, this is going to be a short presentation, just providing an introduction to all these techniques. And what is MRI spectroscopy? It's a technique that allows us to examine the biochemical composition of the brain or a particular disease process like a tumor. It's a technique that allows us to measure the concentration of a selected number of brain metabolites And based on their concentration, we can make inferences about what's going on there, on whether or not it is normal or not. There are several metabolites we can visualize this way, and these are generally visualized in the form of a diagram such as this. This is the spectroscopy, or a normal spectroscopic profile. It was performed over the cortex and subcortical white matter of the parieto-occipital region over there. And what do we see? For a quick and easy interpretation of MRI spectroscopy, we see that the peaks of these specific metabolites, and I'm going to explain what these signify a bit later, they form a steep line of about 45 degrees. This is called Hunter's angle, and this is basically the first thing you can look for a quick and easy interpretation of MRI spectroscopy as Hunter's angle normal. If it is normal, your MRI spectroscopy is very likely normal. Then we see several peaks here, and they also show us some of the most important metabolite peaks in MRI spectroscopy. We see the NAA peak. NAA means N-acetyl aspartate, so it's written over here, so N-acetyl aspartate. And what does that mean, or what does that signify? It's basically a marker of neuronal integrity. So the integrity of the neuronal cell bodies and also the axons. Because a lot of tumors cause destruction of neurons and white matter and replace them by tumor cells, most tumors have a very low NAA peak. This peak over here is the creatine peak. Now, creatine plays some kind of role in cellular energy metabolism. Why is it important for MR spectroscopy? Because it remains relatively constant compared to some of the other peaks and can be used as some kind of reference point. As you see, the choline peak is generally a bit below the creatine peak. So if it is higher, and especially if it is a lot higher, this signifies an increased choline, because these are not absolute concentrations, they are relative concentrations. Choline, finally, is present in several molecules that are involved in the production but also in the degradation of cell membranes. So if you see an elevated choline peak, that is a sign of either new formation of destruction of cell membranes, something that can occur in, for instance, brain tumors. They can destruct cell membranes, but you also have rapidly dividing cells, so a lot of choline because new membranes are being formed, but also in demyelination, for instance, in which cell membranes are being destroyed by an inflammatory process. Is it a useful technique? Well, I think most of us have Neuroradiology, the requisites by David Hewson in our library, and he writes something along the lines of, it's probably not cited at verbatim, but it comes close. If you need MRI spectroscopy to solve a diagnostic problem, go back to page 1. Everything has a low NAA peak and high choline except Canavan disease. Of course, this is a bit, yeah, but I get him, because MRI spectroscopy is rarely the diagnosis maker. It's more of a problem-solving tool when you're really confronted with a certain dilemma, like could this be a tumor or is it radiation necrosis? It can help you decide what is most likely. You can still be off, and a lot of these things look similar, but it can help you shift your degree of probability or your degree of certainty. So it can improve your specificity, especially when dealing with brain tumors and predicting the tumor grade, because high-grade tumors generally have a more aggressive spectroscopic profile compared to low-grade tumors. And it can also help you differentiate or help in the differential between progressive tumor or radiation necrosis, which is a frequently occurring problem in tumors that have been treated with radiation therapy. This is an example of a bithalamic glioma. The question, low grade or high grade? Well, let's examine the MR spectroscopy profile. We see, so this is the tumor, in case you haven't seen it yet. We see that the NAA peak is reduced. We also see that the choline peak is basically where we expect it to be, slightly below the creatine peak. So the ratio, and we mainly examine the ratio, not the absolute values, looks preserved. Then we see this peak appearing. We didn't see that in the normal profile. It was probably there, but very small. Now it's very big. It's higher than the NAA peak. That's myoinositol, which is a glial marker, and it can be increased in low-grade glial tumors and in gliomatosis. So the fact that we see this marker compared with this profile makes us suggest that this is going to be a low-grade glial tumor, which it was. Let's compare that with this tumor. We see a tumor in the right hand knob. This is a recurring tumor. The patient has already been operated in this region, as you can see. Now the question is high grade or low grade. If you look at the one-weighted images with gadolinium, we see no enhancement whatsoever. If we look at spectroscopy on the cerebral blood volume map, we see no increased perfusion. So, based on these findings, we are inclined to say, oh, might be low grade. But let's look at the spectroscopy profile. What do we see? We see a very strongly reduced NAA peak and a very high colon peak. Now this profile is very suggestive for a high-grade tumor. To put it very simply, the lower your NAA and the higher your colon peak when dealing with a tumor, the more likely you are dealing with a high-grade tumor. Just go back to the first case with the low-grade bithalamic glioma and compare the spectroscopy profiles. The difference is clear. Of course, I selected extreme cases for this presentation just to give you the basics. In reality, you're often dealing with peaks that are more between the two, and then it becomes a bit more difficult. But if you're dealing with an extreme situation, it's easier. This is also a frequent problem for which MRI spectroscopy is requested at our institution. These are two people who have been treated with surgery and radiation for a high-grade glial tumor. And in the course of their follow-up, they develop a new mass, contrast enhancing. Now, the eternal question is, because they have been radiated, is this a recurring tumor or is this radiation necrosis? And it's a very difficult differential to make, especially if you're just relying on just your conventional images. We can use MRI perfusion because radiation necrosis does not show neoangiogenesis and will not show hyperperfusion. But I've also shown you an example of a high-grade tumor a couple of slides ago that didn't have hyperperfusion either. So let's say that if you have hyperperfusion, then it's not going to be radiation necrosis. But if you don't have hyperperfusion, it's still tricky. Can we use MRI spectroscopy to help us a little bit? Well, yes, we can. This is the spectroscopy profile of the first patient. And what do we see? We see a strong reduction of the NAA peak and a very high elevation of the choline peak, a very aggressive profile. We also see an increase in this lipid peak, which is often seen in lesions causing membrane destruction. As you know, myelin sheaths and cell membranes contain a lot of fat, so that's causing this lipid peak. And it's also seen in high-grade neoplasms that are associated with central necrosis. So everything combined, this looks like a high-grade tumor, and it was. If we look at the second lesion, we see a totally different spectroscopy profile. We see a very low NAA, choline and creatine peak, almost barely visible. So whatever is going on there, it's basically a process that's destroying everything. If it was a tumor, we would expect a high choline peak. That the NAA peak is reduced is okay, but we would expect a high choline peak because the tumor consists of rapidly dividing cells, so we expect choline to be increased. We also see a lipid peak, which is something you can see in any process associated with cell destruction, and in this case, the cell destruction was caused by radiation necrosis. Now, if the choline peak would have been sky high, then the situation would have been different, and it would have suggested a recurring high-grade tumor. This next case is a very special one. So USM writes you can only use it to diagnose Canavan disease with certainty, because Canavan disease, I don't have an example myself, but look it up on Google, has a very high MAA peak. It is caused by a certain genetic mutation that causes an elevation of N-acetyl aspartate, and it's the only condition I know of that causes an elevation of N-acetyl aspartate. So, but this is another example of a biochemical disorder, an inborn error of metabolism. And I don't know if you see what's going on here. The creatine peak is extremely low. Why is that? This was a patient with creatine deficiency, an inborn error of metabolism interfering with cellular energy metabolism. So this is an extreme case, but in this case, MRI spectroscopy helped us come to the diagnosis, because in this patient there were no abnormalities to be seen on the conventional MRI sequences. Let's now talk shortly about functional MRI. What is functional MRI? It's a technique that allows us to visualize the cortical activity in the brain by detecting very subtle alterations in blood flow in response to specific stimuli. Is it used a lot? No. We can make a distinction between clinical applications, and with no, I mean, yeah, it's used a lot, but in research settings, in daily clinical practice, it's limited to very specific pre-surgical situations, and that's mainly patients with a brain tumor located in the vicinity of an important, functionally important part of the cortex, like the precentral gyrus, Broca area, Wernicke area, and so on. So the clinical applications are quite limited and selected, but it's used a lot for research purposes. Now, how do we get these images? Well, the imaging is based on a phenomenon called the blood oxygenation level dependent signal. This is the technique to generate functional MRI images. And what does it rely on? On changes in the blood flow. We don't measure neuronal activity directly with fMRI. No, what we measure is basically changes in blood flow. This is a normal situation, and we see a blood vessel, we see some neurons over here, and we see oxyhemoglobin flowing through the blood vessel. Now, these neurons, even when they are not very active, they need oxygen. So oxygen leaves hemoglobin in the red blood cells and gets taken up by the neuron and used for its energy metabolism. And what's left behind is deoxyhemoglobin, so hemoglobin not bound to oxygen. And here is another example. So we see some deoxyhemoglobin, we see some oxyhemoglobin in the blood vessels. Now, what happens when neurons become active? When neurons become active, they take up more oxygen. So initially, the amount of oxyhemoglobin in these blood vessels will decrease, and the amount of deoxyhemoglobin will increase. However, this is quickly detected by the brain. It's quickly detected that there is a change in the levels of oxyhemoglobin and deoxyhemoglobin and carbon dioxide. And basically the brain immediately detects from, whoa, my neurons are more active in that particular area. There, I need to provide more blood. The blood vessels will dilate and there will be an increase in blood flow to that specific area. So, despite the fact that neurons are using more oxygen and taking up more oxygen at this moment, because of the increased blood flow, the level of oxyhemoglobin will be higher than that of deoxyhemoglobin. So you would expect it the other way around. If neurons are more active, we would expect to see more deoxyhemoglobin in the blood. But no, something else happens, blood flow increases and the brain supplies, the body supplies the brain in that particular area with more oxygen-rich blood that it really needs. So what do we get? An increased supply of blood, an increased flow of oxygen-rich blood, and an increased concentration of oxyhemoglobin, and as a consequence, a relative decrease in the concentration of deoxyhemoglobin. Now, deoxyhemoglobin is paramagnetic, so it will disturb the MRI signal, and this will be best visible on T2 star images. It will create distortions in the local magnetic field. However, if the relative concentration of deoxyhemoglobin decreases, This also means that there will be a less distortion of the local magnetic field. And this is the basis of the bold signal. The fact that we will see less disturbance of the magnetic field, and fMRI allows us to visualize, to capture and visualize that phenomenon. Here's an example of MRI images of a patient, and this patient is performing a motor task. This patient is wiggling his toes, and what do we see on the fMRI images? We see that there's an increased signal in the paracentral lobule, which contains the primary motor and somatosensory cortex of the feet and legs. This patient is finger tapping during the fMRI examination. This will require an increased activity of the motor cortex in the precentral gyrus at the level of the hand knob. And that's exactly what we see here. We see an increased signal located in the motor area of the arm and hand. So here we see feet activation, here we see hand activation. This is another patient performing several motor tasks. This patient is also wiggling his toes or feet, causing activation in the paracentral lobule. This patient is finger tapping, causing hand activation, and this patient is touting his lips or slightly moving his mouth, causing activation in the precentral gyrus at the level of the face and mouth motor representation area, and that is located lower in the lateral aspect of the precentral gyrus. So we can also, this is a clinical example. Here we knew that anatomically the tumor located here was located in the hand knob area of the precentral gyrus, but the surgeon wanted to be sure that this was an active area and he needed to be very careful during the surgery. So we did an fMRI, patient was finger tapping, and we see motor activation in the bilateral hand knob area located on the right side next to the tumor. So extreme care had to be taken during the surgery to avoid the patient of suffering from an arm or hand paresis. Let's move on to the next example. This is also a patient with a brain tumor. So the patient is finger tapping, and here is a brain tumor. The brain tumor is located in the paracentral lobule and the precentral gyrus, the more lateral aspect. And here we have the hand knob area, and we see motor activation over here located immediately next to the tumor on the left side. So in my experience, based on the anatomical location of the tumor, you can already predict or suggest involvement of eloquent areas, but fMRI provides an extra degree of certainty that these are important areas and special care has to be taken during surgery not to damage them or to spare them, or they can be used to already give some information to the patient about the possible complications of the surgery. This is a patient performing a different task. The patient is performing a word generation paradigm, testing his language functions. And what does that involve? Well, you have a lot of paradigms. In this case, the patient is shown images, for instance, of a chair, and then he has to think of a corresponding verb. For instance, image of a chair, the patient thinks sit. An image of a plane, the patient thinks fly. So that's basically what happens, and this recruits language areas in the brain. And in this patient, the language areas are all located in the left hemisphere, which is the dominant hemisphere for language functions in the majority of both left-handed and right-handed people. So in right-handed people, it's 95%, and left-handed 70%, if I'm not mistaken. So the patient is asked to perform certain linguistic tasks mentally, like verb generation tasks, word fluency tasks. For instance, try to think of as many words as possible that begin with the letter T. There's a word fluency task, synonym-antonym tasks, in which a patient has to give synonyms or antonyms. And then we see activation, typically in the language areas of the brain, which are located in the perisylvian region. We see activation of the Broca area, which is responsible for language production, the Wernicke area for language comprehension. We also see often activation in the prefrontal cortex, which probably revolves activation of working memory functions, and also in motor areas of the face and mouth, probably reflecting articulatory planning. The main indication to do a language paradigm is to determine if you're dealing with the dominant cerebral hemisphere. So if you have a tumor in the left hemisphere, is the left hemisphere also dominant for language, and or the language areas located near brain tumor. This is an example of a patient who performed the language paradigm. We see some activation bilaterally, but most activation, and we also have some artifacts often in fMRI, most activation is left-sided. So I'd say that this is a left-dominant language system. And we see activation in the Broca area over here and in the Wernicke area. And if we correlate it with the sagittal image, the Wernicke area is located in the posterior-superior temporal region and the parieto-temporal transition area. This is the Broca area on the sagittal plane, but we also see foci of activation here in the precentral gyrus at the level of the motor representation of the mouth and the face in this patient. Here we see activation bilaterally in the visual cortex, and well, basically patients are constantly looking even in the MRI scan, and for some of these language paradigms they have to look at images, so it's normal to see activation in the occipital cortex. We also see that this patient has an arteriovenous malformation on the left side. What are the drawbacks of MRI? Well, it has a pretty low temporal resolution. That means when we perform a certain cognitive task that happens in milliseconds, and neural activation happens in milliseconds, but the bolt response takes some time to occur. It occurs after 2 to 5 seconds, which is basically quite long if you want to visualize neuronal activity that takes place in the degree of milliseconds. Also, the spatial resolution is, if you think about it, quite low, because one voxel, so the minimal unit of an MRI image, contains about, I don't know, 100,000 of neurons, making it hard to pinpoint very specific and limited activity to very small cortical regions. And also keep in mind that what we are visualizing is not neuronal activity. No, we measure vascular changes, and we assume that these vascular changes reflect changes in neuronal activity, but it is an assumption. Then, finally, let's provide you with a short introduction on diffusion tensor imaging. What is diffusion tensor imaging? It is an MRI technique based on diffusion-weighted imaging that uses anisotropic diffusion to estimate the organization of the white matter of the brain, and white matter is organized in certain tracts or bundles. Now, what's the basis? Water molecules tend to diffuse along the direction of axons rather than across them, because it's more difficult to diffuse across them because there are so many barriers there, the myelin sheaths, cell membranes, and so forth. So because water molecules will diffuse along the axons, we get anisotropic diffusion. And we can perform fiber tractography, a three-dimensional reconstruction technique to visualize the white matter tracts. So this is the organization of the white matter. So you can easily imagine why it's difficult for water molecules to diffuse across them, and they will preferentially diffuse along the white matter bundles of the brain. And this is explaining the principle once more using some drawings. So these are myelinated axons which form anatomical barriers for the diffusion of water molecules, and water molecules will preferentially diffuse in the direction of these white matter bundles or between them. So this is the main diffusion vector, and it is a lot bigger along white matter tracts than perpendicular to them, which makes sense. So we get anisotropic diffusion, and DTI basically measures the degree of diffusion in each direction per voxel. This is once again isotropic diffusion and anisotropic diffusion, and we see these things over here. These are called eigenvectors, and they basically represent the degree of diffusion in a particular direction. And in isotropic diffusion is the same in all directions. So these eigenvectors will be the same. And fractional anisotropy will be 0. Fractional anisotropy is a degree or a measure for the degree of anisotropy. So in perfect isotropic diffusion, fractional anisotropy is 0. Here we have anisotropic diffusion, and these eigenvectors will not be the same, otherwise it was isotropic, and the fractional anisotropy will be somewhere between 0 and 1 in this particular case, but it won't be 0, otherwise you have isotropic diffusion. So what is fractional anisotropy? Fractional anisotropy, I said it, is basically a value somewhere between 0 and 1 that describes the degree of anisotropy of a diffusion process. If you have 0, it's perfectly isotropic. If it's 1, you have perfect anisotropy. It means all the diffusion happens in one particular direction and there is no diffusion in the other directions. And the more anisotropy you have, the closer the fractional anisotropy will be to 1. Based on these fractional anisotropies, we can create color maps, and you probably know them. They are quite nice to look at, and we basically assign colors to voxels based on two things: the degree of anisotropy and the direction. So basically the orientation of the dominant diffusion vector controls the hue, so whether we're looking at shades of red, shades of green, shades of blue, and the degree or the highness, or how do you say that, of fractional anisotropy will determine the brightness. So how higher fractional anisotropy is, how brighter the colors will be. And these actually already allow us to actually distinguish certain white matter bundles. Like for instance, I here selected the corticospinal tract, which goes from the precentral cortex to the brainstem. Here we see very nicely the genu and the splenium of the corpus callosum. We can see the internal capsule and the external capsule. This is going to be the optic radiation. So we can already distinguish them a little, but still it's not easy to look at. You have to scroll through them and you lose track. So there's a technique, the fiber tracking technique, that allows us to actually make some kind of estimate of the course of white matter bundles. And it's a mathematical technique. So we start at a certain region of interest, and then the algorithm looks for adjacent voxels whose main diffusion direction is in continuity with the previous one. And it's based on the assumption that if you do that, you will track a certain white matter tract or a certain white matter bundle. And then you get images like these, which are very, very nice, but in the end, also based on an assumption and a mathematical model. So it's not a direct visualization of the white matter, it's what we think it is based on the calculations of the diffusion values of the brain. So what are drawbacks of diffusion tensor imaging? The spatial resolution, which is quite high, taking into account that the diameter of one axon is less than 1 micrometer. So we're not visual, so it's very difficult to visualize a very small white matter fascicles. One voxel contains many axons and very different directions, or other tissue types, which can disturb the image or make interpretation difficult. And of course, it's difficult when you're dealing with intermingled white matter bundles or smaller white matter bundles. Further drawbacks, as said, it's an indirect method. It's inferential. We assume that these diffusion values, that these images we created based on the measurement of diffusion values basically reflect the course of white matter bundles, but false positives and false negatives are possible. And we always, especially if we use it for scientific purposes, we basically have to correlate it with dissection studies or tract tracing studies. We need a gold standard to be sure that what we are visualizing when we do like fiber tractography is a real tract and not something generated by the algorithm. So that concludes my introduction to advanced MRI techniques. It's a pretty short presentation, but it's just something to get you going. I think getting familiar with the basics in radiology is the best way to learn radiology and then build upon that. So in the future I might go into a little bit more detail, but so I hope you found this interesting. If you have any questions, comments or feedback, leave a question, comment or some feedback in the comment section, and you can also email me neuroradiology, here it is, .online@gmail.com. So thank you very much for watching.